Dr. Elan. Elan is going to tell us about how he calculates IOL power in aphakic patients for secondary intraocular lenses. So before Elan is on the stage, Dr. Anaga, do you have any cutoff for how many will be angle alpha? Yeah. So actually, there are two schools of thought. There are two schools of thought which believe that it is irrelevant. There's no point. In fact, when I reviewed my old patients, when I was not measuring angle alpha for any of my patients, I didn't find it relevant. But today, now that I measure for all my patients, I think 700.7 mm, I think is what the cutoff that is recommended. But there's nothing hard and fast. But it was a very well-made talk, Anaga. Yeah, so we go for a lens which has a bigger central button. The central button has to be, that makes more sense. Yeah, thank you.
Thank you, sir. At the outset, I would like to thank the President, Dr. Arup Chakravarti, Scientific Committee Chairman Srini, the entire Scientific Committee and KSOS for giving me this opportunity. The talk is on IOL calculation in aphakic and secondary IOLs. Most of us very rarely see an aphakic nowadays. But still, we have certain cases where certain cases where we still encounter aphakics as well as the need for secondary IOLs such as piggyback or replacement of an IOL. All of us are familiar with this. The point to be noted here while doing an aphakic IOL calculation is to, number one, set it to the aphakic mode. Dr. Sandhya here spoke very well about the different velocities in the eyes. So set it to the aphakic mode and then go ahead with the calculations. Now when you calculate, please look at the graph. It will be something like this, just like how Dr. Sandhya was showing. The anterior and the posterior part of the lens capsule, but in case of an aphakic with an intact capsule, you will see only one. This is a silicone filled eye. I've taken it from the net only. This is not mine because nowadays almost we have stopped doing ultrasound biometry. Now the same thing in case of an optical biometry, again you can go and set it. Normally it is set in the aphakic mode. You can always set it to the aphakic mode, or in case of lens exchanges, you can always set it in the IOL mode, be it acrylic or otherwise. And once you do that, exit this setting. There's something we have to teach any new optometrist, and then you can see the right eye we have set it in the aphakic mode, and the left eye still remains in the aphakic mode. That's how to go about with an optical biometer. The second thing, what we should know is, if at all, if the lens is placed in the sulcus, what should be the change? And almost all of us, previously we used to just use some 0.5 or 1 depending on where we place the lens. But then with this nomogram, we are nearly accurate. It's available on Dr. Hill's website. So this is what it says. For each power, there is an error that is given and then the correction that is denoted. So if you go from here till 9, there is no need to change the power if the lens is placed in the sulcus. 9 to 17. We need to do a 0.5 change. 17 till 28, 1 dioptric change. And anything above that is 1.5. When you look at it, what do you notice? These three things, 9, 17, and 28. Now what is this? How do we remember this? We can take it as 9, 18, and 27. And remember it as the rule of 9, so this is a thumb rule, because in the OT will be tensed. We may not have this. Best is to stick this in the OT, but if this is not available, remember the number 9 and then go ahead. Now how do we place the IOL? There are multiple options which are available. It could be the single piece IOL itself, if the capsule is intact, or a multi-piece IOL, either a scleral fixated or otherwise, anterior IOLs and iris claw IOLs, or the recent ones, intrascleral haptic fixation or suture fixation or glued IOLs, whatever that be. So each of them we're going to see. Now let's remember, if there's a small defect in the capsule and we have abandoned putting a lens for any reason, and if the capsular is adequate, if the capsular support seems to be adequate, we can still go ahead with even the single piece IOLs or preferably a multi-piece IOL, so that in case something happens, we can always change our procedure. Now, only in the bag, no change is required. The same whatever measurements we get, we can go ahead. But sometimes we might have to place the lens in the bag. The other lens, the Rayner Centroflex design lens, that cannot be done. But in these cases, an optic capture can be done. It can be done even with a single piece IOL or with a multi-piece IOL. Placing the optic in the bag, haptic in the sulcus. Haptic, you just place the lens in the sulcus and push the optic down. Again, because the optic is going inside the bag, either it is a no change or a slight change. What do I mean by a slight change? We saw the nomogram. If it is 0.5 change, no need to change it. That is, till 17, 18 diopters, no need to change it. 18 to 28, we had said 1 diopter there, so half of that, 0.5. 28 and beyond, instead of 1.5, we use a 1 dioptric change. That's what we can do with this. Now, if the haptic is in the bag and optic is in the sulcus, haptic is in the bag and optic in the sulcus. This happens, we have already inserted, but there's a threat of, we feel that it may get decentered or sunk. So what we do is we just pull out this is called reverse optic capture. In this case, apply the rule of nines, whatever we said, because it acts as good as a sulcus lens, so do that. Now what do we do with AC IOLs and iris clip? Believe me, even now we see a few AC IOLs, well done AC IOLs, holding on even after 20 to 30 years. So it's not the lens that was the culprit, it was the method that was done was a culprit. So what do we do for this? Always there is an appropriate A constant given by the manufacturers. Most of us have not did large numbers with this, but if you have large numbers, you can have your own customized A constant too, but better to use the what the manufacturer provides till then. Now in case of scleral fixation, what do we do? Scleral fixation, I mean either the suture method, glue method, or intrascleral haptic fixation. Again, no change. Why is this? Remember, most of the times we are entering 2 millimeter behind this area, behind the scleral spur, almost a millimeter behind the scleral spur. So it's as good as placing the lens in the bag, so there's no need of a change. Some of the surgeons whom I know still incorporate that slight change, what I was talking about. So these are all the options that are available in case of an aphakia. There are other methods to calculate also. One is the biometer method, which I said. There are other methods. We'll come to that later. Now, sometimes it happens for a refractive surface, we have to change the IOLs or add a piggyback IOLs. How do we go about this? Let's take this case. This was my first case where I had to do a, okay, I'll just fast forward it. What did we do? If you can notice, we have taken it in the acrylic mode, and this was the, sorry, I'm not able to play that properly. Okay, we'll skip it. It was taken in the acrylic mode, and because we were going ahead with a scleral fixation, same power lens was used. However, this was a case of retinitis pigmentosa. His vision was only, I think, 6 by 18 or 6 by 24, but look at the refractive result. This is what we got. That same lens, what you saw as a subluxated lens, I had put it in 2009, and this was repeated in 2017 or 18. Now, there is a refractive surface. Surprise, how do we go about it? My preferred method is this. Go to the APACRS website, choose that Barrett treatment formula, RX formula, and then fill in the details. Now, this first slide I've given, see what is happening. Lens thickness, when I try to feed, this is what it shows. It doesn't accept a smaller lens thickness. So a pseudophakia. So next slide, I just removed that, entered the readings, calculated, and this is what I got, 22 diopters. Now, the same patient, if we were to put a piggyback IOL, again there is an option to calculate, that would be 7 diopters. Sorry, this was another patient where the error was 5 diopters. 5 diopters, yes. It's been entered there, 5 diopters. So if we have to put a secondary, exchange the lens or do a piggyback IOL. This is one of the best methods. This is what I follow. There are other methods that can be followed too. Another method where you can download the entire Excel sheet is from the Hillside, feed in the readings. These readings are to be filled. This is automatically calculated, and then you get the power here. There's a difference of around 1 between this and that. The reason is I've entered here as 5.5. Even otherwise, I think we get a 0.5 to a little bit more than that. If nothing is available, then you have the Gill's nomogram. Remember these three numbers, 21, 22 to 26, about 26. Below 21, remember this, if you are adding a piggyback lens, remember this formula, 1.5 into spherical equivalent. Medium-sized eyes, it would be 1.4, and for a large eye, it would be 1.3. Now, in case the error is a plus power, if it is a hyperope, in which case you have to add +1. If the same thing, sorry, that's a spelling mistake, there should have been a myope here. If it's a myope, then -1 from this. This is the way to calculate. If you had looked at my that 5 diopter error which I had, all the three formulas come within a gap of around 0.5 to 0.75, 0.5 to 0.6 dioptric of difference. So we can use any one of these to calculate the lens and place it in the eye. Once again, I thank KSOS, Dr. Arup Chakravarti sir, and Shini for the opportunity. Thank you.
Thank you, sir, for the excellent presentation. Now we'll move on to the next presentation, Dr. Adavind More. As we know now, retinal surgery is being done quite often. We'll encounter with eyes filled with silicone oil. So we'll be talking on IOL calculation in silicone oil filled eyes.
So, Elan, that was a very nice, very practical presentation. There are a few just add-ons I would like to make. Number one is, we go for, usually Salcoflex is from Rayner. So they have their own side, Rayner.1. So we can calculate it is very easy because all the lens features are incorporated there. Second thing is, that when you have to place a lens in the sulcus, I'll stop as soon as Arvind comes on screen. Please bring him on screen. I'm just trying to fill up the space. So I use a 5% this thing. Sometimes I also have a whole thing printed out on my OT, but I use a rule of 5%. So even if you just apply 5% correction to the power, but what you need to remember that it is not, supposing if you have calculated for a Technis 1 or a IQ for bag, the 5% formula of this nomogram does not apply to that lens, to that particular power. It has to be the same lens which is going to the sulcus, that has to be incorporated. So this requires a little additional exercise which is done before surgery itself. Lovely presentation, Elan.